Our next speaker is Dr. There's a little change in the order because of overlapping presentations. Dr. Karobi LAHIRI, who's the Director of Vitreoretinal Surgery at Bombay Hospital, and a very prolific surgeon and who's an expert at ROP surgery. She'll talk to us about nuances of PVR management in the pediatric population. Pediatric age group, the vitreous is more formed, more adherent, and they have all the growth factors, etc., are much stronger in them, and hence the PVR is also of a more malignant variety, if I can call it so. So meticulous management is very essential. Dr. Karobi.
Thank you, Paritosh, for including me in your IC. I am going to talk to you about the nuances of PVR in the pediatric age group. Now, these are the whole gamut of conditions where you can get detachments in children, which can be of the tractional nature or a hemorrhagic RD, or it can be of a heterogeneous variety. And of these, the most important are the traumatic ones and the ROP, and also congenital malformations such as Stickler's syndrome and all the other syndromes which also occur with retinal detachments. So we have to know that pediatric retinal detachments with proliferative vitreoretinopathy is a very complex condition, often presented with chronic macula of detachments, poor visual acuity requiring specialized surgical intervention. And if this is accompanied by nystagmus, strabismus, hypotony, cataract, uveitis, and leukocoria, you can be sure that this is a poor prognosticator and they are indicators of chronicity. Now, pediatric RD is often detected later than the RD in adults. Why is it so? Because children many times mask their visual defects, and sometimes they don't even come to know if it is unilateral, and these leads to delayed diagnosis. Typically, the visual acuity is poor, and to tell what is the duration of the RD is very difficult. Pediatric RDs can be missed out also on initial examination because either there is poor fundus visualization, secondary to non-cooperation, media opacity, or incomplete mydriasis. PVR in pediatric age group, the challenges are due to unique anatomical and physiologic characteristics, and the characteristics are faster progressions, more cellular proliferation and contraction, and therefore it increases rapidly. It's very aggressive and gives rise to aggressive scarring and complex surgical management. Difficulties are that apart from all that we have said, the PVD does not occur. The PVD creation is much more difficult because it is more complex formed vitreous, and the membranes are more difficult to peel. The surgical challenges are because the eyes are small. There is an underdeveloped pars plana in most of the ROP cases, premature cases, and also in children. The retina is very fragile, so the complication of iatrogenic breaks is more. Lensectomy complicates these issues because you have issues later of the child going amblyopic, and you require other devices to make the child see. Higher recurrent rates of PVR needs multiple surgeries at time. The retinal stiffness from scarring makes the reattachments very difficult. Problems are of anesthesia because these have to be under GA. Positioning is very difficult because they won't listen to you, and no standardized protocols are there. So just to see that this is one of the videos which shows that there is no formation of the PVD at all, and you really have to sort of take it off from the surface. And if you get hold of an edge, then you have to slowly peel it off. And the peel becomes very gradual. It's very sticky. It kind of adheres to the surface of the retina. So your progress has to be very slow, and you have to do it very cautiously and patiently. And finally, you've achieved the separation. The next one shows a little more worse case. where it has formed a star fold at the optic nerve head. There are membranes which are contracting the retina. This child had a unilateral detachment, didn't even know there was a detachment. He came for a routine evaluation with his parents, and that's how it got detected. And this had to be removed under PFCL. There's a whole chunks of membranes which are there on the surface. The ILM peels, yet there is a kind of a fold at the macula. And after straightening out, doing the endolaser, that is at the conclusion of surgery. A third patient is a patient of trauma. You have to be sure that you have peeled off the entire PVD, all the scarring, and you have to do a patient job even if it takes time. And this is where, after you've cleared the retina, cleared the vitreous hemorrhage, you go ahead and so the key to optimizing outcomes is for an early diagnosis, for tailored surgical techniques and long-term follow-ups are very important. Now, the pediatric RD has a worse prognosis than an adult. The RD, due to higher incidence of delayed presentation and macular involvements, is the reason for the same. And their more common initial presentation is because they tend to develop these kind of membranes in the subretinal region. So if you have a patient who has got a lower grade of PVR, it is better to do a scleral buckle rather than jump in for a vitrectomy, because if you create the tamponade by a buckle and the drainage, and the retinal pigment epithelial pump is healthier, so it pumps out the subretinal fluid also better, and the visual acuities are definitely much better than what you would get if you had sort of attempted a vitreous surgery. But if the firm adherence of the pediatric cortical vitreous makes the pars plana vitrectomy more challenging in these children, and there's a potential for iatrogenic breaks during the induction of the PVD. And if there is an incomplete PVD removal, then you can land up with a recurrent detachment and multiple surgeries thereafter. And this can be assisted, the PVD induction, by triamcinolone staining and a flexible loop scraping. Segmentation can be an alternative to delamination for preretinal fibrosis tissue removal. Now, another technique is whereby you remove the mid-peripheral vitreous first, so that it separates the vitreous of the periphery and the posterior pole. So then sort of causing a little traction on the posterior vitreous becomes much easier thereafter. But in unavoidable situations where there is higher grade of PVR, you have to do a vitrectomy if there is also a vitreous hemorrhage, or if there is a cataract or lens subluxation, a giant tear, coloboma, or recurrent RD. So you do the procedure which I just spoke to you about. A lens sparing vitrectomy is ideal because then the prevention of amblyopia and glaucoma is there, and cases with choroidal detachments or funnel RDs need a limbal approach many a times with lensectomy. So robust postoperative inflammatory response worsens the PVR in the postoperative phase. Poor compliance to medication leads to excess scarring. Long-term visual outcomes are poor. There's a risk of amblyopia, so you have to address that also. And poor central vision is because of macular involvement many a times. So the facts are, when there are single surgeries, the success rate is about 73.3%. The reattachments are better for traumatic and lower for congenital or developmental retinal anomalies. Amongst all forms of primary retinal detachment, the traumatic and the recurrent retinal detachment have a better anatomical success rate than the TRDs. And despite a range of wide surgical approaches, PRD has a low surgical rate of reattachment compared to that of an adult RD. Even successful anatomical reattachments, the eyes are often at a risk for amblyopia. So what are the potential solutions for the future? Early diagnosis and treatment, adjunctive therapies with anti-VEGF, steroids, anti-PVR agents, improved surgical instruments, smaller gauge instruments, better tamponades, and amblyopia management. And co-management with a visual developmental specialist or a pediatric ophthalmologist is essential for maximizing functional outcomes in a pediatric retinal detachment patient. Thank you for your kind hearing.
Thank you, Karobi, for a wonderful presentation. The one tip that she didn't give, and which I have learned from her, apart from a lot of things about ROP, etc., is that she is very compassionate with her patients, and that's what wins over the patient and the patient's cooperation, because small kids, you know how cranky they can be.
Yes, so you have to make all kinds of animal sounds with them. Then they listen to you very nicely. Thank you so much.
Thank you, Karobi.
Thank you.
Thank you.